And now, by the magic of technology, we should have Dr. Sharmistha Ghosh, and we do. Welcome, Dr. Ghosh, and thank you very much indeed for agreeing to do this for us. So we've never done this before, so we'll give it a go. So we've just heard from Ben Solomon with a lot of science in there as well, but a nice hopeful message at the end. So I'm going to open up the floor to see if we've got any questions, and we have roving mics. Yes, we do. Right, hold on, Dr. Ghosh.
Hi, good morning. Deborah, thank you for bringing great speakers. Honestly, these are the best in the field. I have two questions. Although Dr. Solomon gave a good explanation why he chose crizotinib, or to compare with crizotinib in the CROWN study, it seems everyone is keen to compare with a compound that doesn't work well. When will we see comparison between, for example, lorlatinib and alectinib, which I think will show very close curves to each other?
Thank you very much. That's a great question. And actually, I have to say that when that trial was being developed, he's right. It was at the time that the ALEX trial was still in, we were still recruiting into both the ALEX trial and the ALTA-1L trial. So at that time, crizotinib was the best one. That was the only one that was actually reimbursed and used worldwide for ALK positive lung cancer. And then very quickly, we got the data from ALEX, and then literally a few months later for ALTA-1L with brigatinib. And by that point, the trial with CROWN had already gone too far for the team, for the sponsors to go back and change. And we definitely wouldn't have had any data at this stage about lorlatinib against any TKI if it had stopped then, which was a shame, because you're right, it kind of, when you see at the beginning what it was compared to, you're all thinking, well, that's not really maybe relevant to where we are today and what I'm on now, for many people, and I would hope most people actually. I wouldn't want to see somebody necessarily first line on crizotinib here in this country. Anyway, moving on from that, we are where we are with that data, and we can still get a lot of good use with that data and see if lorlatinib, which I think is likely to happen, will come into use in the first line setting. Whether or not we see the sponsor with lorlatinib doing anything with lorlatinib against any of the other two second generation TKIs, alectinib or brigatinib, I don't think they're going down that track. But I think we need to look to the fourth generation TKI. And I know for a fact that that will be used in comparison. I think you're going to hear from Nuvalent today, but that will be used in comparison to second generation TKI, so to alectinib. And at the moment, they are actually recruiting to many sites. I know that firsthand, actually. So I don't think we will have to wait long to look at maybe not lorlatinib with one of the better TKIs, but certainly NVL 655, and I'm sure other ones as well. And Ben also mentioned many Chinese TKIs as well. So if another TKI is going to be trialed in the first line setting, we will not do it. It will not be done against crizotinib now. It will be against one of the other ones, and that is imminent and coming very soon. But I wouldn't, still dismiss what we have from the CROWN data by any stretch of by any means. Does that answer your question?
Yeah, thank you very much. My other question is to Deborah, actually. This is the first time I hear an oncologist use the word cure, and I was very pleased to hear it. Of course, he's probably thinking in the setting of using ALK on an early stage, but he also mentioned it in the context of a stage 4. Now, knowing what we know about progress-free survival, are you aware of any patient, whether in this group or outside this group, who have exceeded the maximum progress-free survival expected from the studies? I know he's given an example from Australia, but do you know of any, so we could be inspired?
So we have a member in the group that she isn't here, and she's coming up to 14 years survivor, and she's in the Facebook group. Her name is Maureen Sawyer. So and she very often responds to people's posts. So if, you know, make contact with her.
Is Maureen happy? And people like Maureen, patients like Maureen, are they happy to give us a talk and tell us what they do in life? You know.
She's a bit shy, which is why she doesn't come here. Okay. So I have asked previously, and I've said you would be a massive inspiration to us all. And she prefers to stay in the background. But there is someone in the audience that's already nearly 12 years.
And I think Dr. Gomez also wants.
Yes.
Yes. Sorry, I wanted to. I think I have patients too. I can't mention their names, and you know, obviously for anonymity. But yes, it's. I want to push on that kind of enthusiasm and that inspiration. That I hope it's not the first time going forward that you'll hear the word cure in the same sentence as ALK lung cancer, and not just for the patients in the neoadjuvant setting or patients who have got a little burden of disease. I really hope that, and I've mentioned it before at previous conferences with Deborah, that word cure along with metastatic ALK lung cancer. And I really am very, you know, what's the word? Just, we have to be inspired and push forward with that. And it's certainly becoming less and less rare. I mean, Deborah's just given a couple of people within a number of seconds of patients who have lived for a good length of time with metastatic ALK lung cancer. So yeah, I just want to confirm that as well.
Thank you for sharing this, and congratulations to those patients, and hats off to them. And I'm sure it's more than just a pill that is helping these patients achieve. So, you know, if I manage to do, I'm still in my second year, but you know, if I manage to do it, I will come to this stage and share what I've done with others. But please do consider this for the next courses.
Absolutely, and we do have at least half a dozen who have done 10 years or more in the Facebook group. So, so there are a lot of people that we can get inspiration from, and we do have some of their stories on the website, but we will continue to gather them. Now knowing the nearly 12 years is in the group, so but they have already agreed to be featured in a piece. So that's fantastic news. So we'll have her story before very long.
And that's what we call in medicine real life evidence, as opposed to studies.
Yes, absolutely. And we all need to know because none of us know how long we have. Yes. So it's inspiring to hear from others. Any other questions from this?
Yeah, hello. My question's quite similar, actually. I'm not a patient, I'm a carer. But it really is, 34 months is the sort of 50% is a median point. And we were just wondering, similar to the last speaker, what is the lifestyle of the people that live above that line compared to the people who live below the line? Is there any lifestyle studies on that side of things?
So that is something that we are doing now, actually. There isn't a lot. So the only ALK trial, and I'm talking about the first line ALK trials, comparing against crizotinib, and then the crizotinib versus chemo trials, that the two trials that Ben spoke about. So out of those 5 trials, there is only one which actually specifically looked at the patient's quality of life, our quality of life when we are on this TKI. And they use proper, quality of life measures, of course, with patients contributing very heavily into assessing what their quality of life was like at diagnosis and all the way through, and then after as well. So even when they'd finished their first line TKI and then moving on, and that was ALTA-1L, so that was the trial which was brigatinib versus crizotinib, and that was back in 2018. That was at World Lung, that data, along with the survival data, was presented. So what I'm trying to say is there's only one that's official where we're looking at quality of life data, and real world data is only now becoming something that we need to look at, and we realize this. And I think I wouldn't blame the oncology world for doing that, because in the past, before 2007, before the advent of the ALK TKIs, we didn't know that we were going to get such fast-moving education and science and research in ALK lung cancer. So we are doing it now. There are many little real-world projects going on, looking at patients on different TKIs. It's really, really important now to assess this. because the one thing with TKIs that we knew about up until a few years ago were that TKIs were actually very well tolerated. And versus chemotherapy or immunotherapy, they would definitely be the choice for patients and for doctors and nurses to give to their patients, because in general they were very well on the tablet, very easy to use, and people could hopefully get on with their lives as much as they could. Ben commented on it, and you know better than me, for those of you who are maybe on lorlatinib, and I don't think everybody experiences a bad profile of toxicity on lorlatinib, but it is significantly different in general than the other TKIs. And if we are looking at using that lorlatinib in the first line setting, we do really need to look at what the patient's life is going to be like for that length of time. So it is happening, and we are actually doing studies, even in the UK, for looking at real world data on different TKIs and how patients actually are feeling on it, because that's the main thing. You know, we can have years and years of life. That's what we want first. But once we've got there, which is where we are now, we need to make sure that the quality of life is good with that. So we are just at that point now. Does that answer your question? It's a long-winded way of saying we only have one and we're getting there with more, and we are doing more now.
Thank you very much.
Anybody else got any questions? Yes, we've got one coming. There we are.
Hello, I would like to comment on this aspect. So there is a longitudinal study which is led by the US ALK Positive community. So I understand that some people in this audience actually contributed to this study, and this is exactly the study which addresses the lifestyle and other components of conditions related to ALK positive lung cancer. So I think there have been updates on the summit about the longitudinal studies. So it's a comprehensive, I participated into this study from the beginning, and so it started about 2 years ago, and it continues at the moment, I think. And I think you still can engage with this study if you want to, but they cover a lot of questions around lifestyle and treatment options and all kinds of things which are related to ALK positive lung cancer. So there may be some data actually from some preliminary data from it. Maybe Yvonne, if she's around, could comment on this as well, because she attended the summit. And this is a comment. I also have a question.
Can I just comment on that? That is, I know exactly the study that you're looking at, and that is great. And that was based in the US, I think. I think I missed the first part of your comment. And we've actually looked at
it was in the US
as well, separately. Yes, but it's not.
But it's worldwide, so you can contribute.
And my point was, it wasn't part of any of the phase 3 trials, which is what I mean. I think we need to have these embedded and engrossed within the scientific research to really lift the profile. Because there's that one going on there. Yes, they've gone worldwide. There's smaller ones within the UK, which different centres contribute to. But we definitely need, like the ALK project, for example, which was a UK-wide one. But my point is, I think, adding to the gentleman's kind of question from before, that those need to be raised and embedded within our phase 3 clinical research and scientific research, and have it up there as on the same platform as looking at all the cells and things in the lab. I think that's what you were saying as well. I missed the beginning of your comment.
The beginning of the comment was that there is a comprehensive lifestyle-related study called longitudinal study, originated at the US. And this study actually addresses a lot of questions, I think, which the gentleman was asking about contribution of lifestyle factors into how this disease is managed and progressed.
Do you have a question, Elena.
So I have a question about the Crown study. So regarding the crizotinib arm, was there crossover allowed to people who progressed on crizotinib in this study?
Ladies and gentlemen, we are going to resume the opportunity to ask Dr. Ghosh a question. So when the roving mic comes round, can I make a request that you hold it quite close, because it helps with Dr. Ghosh being able to hear your question. So where are the rovers? There she is, Dr. Ghosh. Good to have you back in the room. Thank you. Right, we'll go back to Elena with her question around the Crown study, because I think that's where we lost you. So, Elena.
Yes.
Hello again. I hope this works now. My question was about the design of the Crown study. I would like to know about the crizotinib arm, whether people who progressed on crizotinib were allowed to cross over. Meaning that what kind of treatment they had after they progressed, whether they were allowed to have the second line treatment, or what kind of treatment, or not.
So, just to be clear.
They weren't able to cross over.
Yes, were they able to give, so the ones that progressed in the crizotinib arm, were they allowed to cross over? And if so, what did they cross over to lorlatinib
Or else,
or anything else?
or alectinib or brigatinib, or not at all.
Yes.
So technically, crossover within a clinical trial means you cross over to the other arm. So within the trial, patients were not permitted to cross over, so they weren't able to have crizotinib and then cross over to lorlatinib within the trial. With the trial, then I suppose it would be up to clinicians' discretion, and then with the patient on the type of treatment those patients were then able to have, or what they would want to give their patient, and that would be out with the trial. So you couldn't cross over to alectinib anyway within the trial. If you were going to cross over, it would have to be to lorlatinib, but that was not permitted within the trial. But what I'm trying to say is, I suppose, if once you're off trial, then you can go on to other treatments as to what your clinician would deem appropriate. But that wouldn't have been recorded within the trial data.
No, but what actually happened to these patients who progressed on crizotinib?
They went back to their original. Sorry, Dr. Ghosh.
So that
they
would
went
be
back
up
to
to
their
the
original
clinicians.
consultant. Sorry, go on, you go ahead.
Yeah, so exactly. So say, for example, I had a patient who is on the trial, then it would be, you could go on to your second line treatment, which would be lorlatinib, but off the trial, or chemo, or, it would be, but it wouldn't be within the remit of the trial. So as Deborah is saying, you would go back to treatment off trial. So standard of care treatment, it would be deemed. I think that's what you were trying to say, Deborah, is that right?
Yes.
Yeah, okay. And I don't have data or access to exactly what happened to all those patients, because that, I'm not at liberties to go through that. But it can be assessed and looked at, I'm sure, but I don't have access to that now today.
Okay, thank you.
Anybody else with any questions?
Has it gone again, the sound?
Well, we have Dr. Ghosh here. Yes, there is a question over the other side of the room. Yep, I've got you, Duncan.
Hello, Dr. Ghosh. So I'm sorry my question's going to be a bit down in the weeds in terms of understanding some of the data we're shown when we see this trial data, and it's about what we see on, and this isn't unique to Crown. I think we see in it a lot of the Kaplan-Meier graphs that we see for TKIs, usually for PFS, but sometimes it's overall survival as well. is we always see the same graph with the curve coming down and then flattening out at whatever point, depending on the drug. And then what we also see, and this is sort of where I'm getting into the weeds now, is the graphs have what are called these sensor points on them, doing where someone's taken out of the data, but it wasn't because they progressed or they died, so it's not affecting where the graph is on in terms of it moving further down. But what I always see on these graphs is that the number of sensor points towards the end of the trial steps up massively, always. And I don't understand what is going. Is that just the trial winding up at different centres, or is it something else that's hidden in the data that we don't see? I don't know. I know it's quite a hard question to answer.
I think it's only hard because I suppose it would be you could show me a graph and say each little tag is like an event.
Yes.
And different trials will have different ways of defining their events. So in some trials, it may be that they've received some local treatment, but they've still remained on it. In some trials, it will be that the patient has come off the treatment. In some trials, it will be that they've passed away, but that would be more looking at overall. That's more overall survival, and also that will be more when you're looking back at data, kind of retrospectively. So I think it's a difficult question to answer only because it would be different according to what the endpoints of the trial were and which trial and at which point you're looking back. So for Crown, it's difficult because they've had 3 kind of assessments. They've had one at the median number of months was way early on. Then we had one at 3 years and then one at 5 years. So you're going to get definitely more towards the end of the 5-year one, maybe. I suppose what else I was going to say when you're talking about the lines flattening out, that's a good thing. That means that the patients are staying, there are no drops. So that's why you're getting more on a line as well, because the lot further and further you're getting away, there's no sudden drop. So then the longer and longer you go, there's going to be more and more events happening because you're assessing for longer. But at least the shape of the curve isn't coming down. Does that make sense? It's not
I think
dropping
it's
off.
basically what I was thinking it was. So it's people coming off the trial for another reason other than progression, or like you said, maybe they've had some LCT, but stayed on the drug, and it's things like that, I guess, that are making the difference. But yeah, it was just one of those things that it was not totally clear, and I couldn't understand why you've got so many of these events towards the end of the trial, and that seems to be the case not just on Crown, but across all of them. But yeah, okay.
The one thing that you will know from Crown, though, which was the big thing, so when those curves were first shown, and even in the advisory board meeting, for example, we were all eight of us on the board, just at how long and that line. One of us actually commented, "Will that line ever drop?" The extent, and that's something that's unique to Crown rather to any of the TKI trials. And I think Ben mentioned that as well in his, that's something that's unique that we're seeing. And then how we can then go on to cure. So you can be like that, the word cure, and why you're able to talk about it more, because we are actually seeing this line with lorlatinib in the Crown trial, with it just staying stable and not any drops, even though there are events. So you're getting very good, data, which we have not seen in any of the other ones. And it's still immature, which is the thing. Does that make sense?
Yes, thank you.
Yeah.
The question, I believe, yes? Right.
Why does it take a year or 2 for drugs to be approved in the UK? Noticed on the dates on Dr. Solomon's slides that drugs seem to are approved earlier by the FDA than they are here. Why that difference of a couple of years or a year or 2?
It shouldn't be 2 years between America and us. I mean, but there always is a delay. 2 years is a long time. I agree. They have different, you know, they will get their things approved, and then they don't have to go through the reimbursement procedure as we do here in the United Kingdom because of the NHS. So you can have something approved here, but then maybe not reimbursed, of which there shouldn't be a long length of time either. So in America, it's FDA approved. Yep, you're good to go, and then they don't need to go through the whole reimbursement thing. So that's one reason that actually for us to get our hands on the drug could take a bit longer. We you know, NICE are now you know, almost they're not overworked, but there are many, you know, it's not just ALK lung cancer, and it's not just lung cancer, and it's not just cancer even, you know, that NICE are sitting with people and different groups and organizations, not just oncologists, to go and say, you know, we need this medication and we need that. So there's that as well, that they're just overworked. We're doing well in ALK lung cancer, we're doing well everywhere in our research. But usually we will try, so, you know, yes, I agree there is a delay. It shouldn't be as long as that. And we do need to work harder to get that time frame smaller. But the main reason that there's a difference, however long that difference is because of the reimbursement side that we need to go through here in the UK, sadly.
We have another question.
I don't know if
for
that's
you.
helpful.
Yep. Right, we've got another question. Yeah?
I don't know whether this has been, I've missed it during the conference, but it was the point of lorlatinib being first line rather than later on. And also, I mean, the graphs aren't someone who's been on crizotinib, brigatinib, you know, the length of... I was on crizotinib for 18 months, and apparently that was quite a long time. And I was glad then that I had other drugs in front of me to go to before chemo, for example. I had brigatinib, which is still in, you know, testing stages, and then lorlatinib. But first line lorlatinib, what's happening to alectinib and brigatinib and the others? There's nothing at the moment. There's nothing in front of it. I mean, unless you're that confident, not just you, but the science community are that confident that everyone will take to it. You know what I mean? There doesn't seem to be an option.
Absolutely. There should be an option, and I think that's the thing. We want to try, and I think there should be a case of you're not just an ALK patient, a patient without lung cancer, but everybody's different, and everybody's cancer will be different. So I think it's likely that lorlatinib will get, we're already able to use it in Scotland, for example, in the first line setting, and I think it's likely that that will come in England and Wales as well in you know, I know when the date is, but yeah, it'll be in the foreseeable future. And at that point, it would not be that you would have, you know, every patient who's then diagnosed with metastatic ALK lung cancer would then go on to lorlatinib. There should be the choice, and there will be the choice. It doesn't affect the fact that we still have good data for alectinib and brigatinib. And even, I mean, crizotinib is still licensed as a first-line treatment, for example, so as is ceritinib. So those options do not, what has happened in the past and the data that we have in the past is still very relevant and can still be looked upon and used. What each clinician decides to do with their patient will be very individualized, and that should remain to be the case for a long time coming, because you know, you shouldn't just have one choice and that's it. Well, otherwise, what's the point of us all working so hard to get all these different options?
I think,
So as long as you have an oncologist who's sorry, carry on.
Sorry, I was going to say, I think the question was more geared towards second line after lorlatinib. So am I right?
It is, and
Yes.
also I was glad that I managed to make the others, well,
Yeah.
crizotinib anyway, last so long before I went into another one.
Yes.
I had resistance, and the next one I had a little trouble with. Now lorlatinib. Now I'm hoping that, you know, goes on and on, but if it's at first, I've extended in my head, maybe I haven't, but I feel as if I've extended the time that I might have with lorlatinib by being on the others. I mean, I don't know whether that's completely silly.
Yeah. Is your question more then, if someone receives lorlatinib first line, will they then be able to have brigatinib or alectinib or crizotinib second, third, fourth line?
Well, no, because it's better. It's supposed to be better than the others, isn't it?
Correct. Yeah. So that's right. So you wouldn't be, if you have lorlatinib first line, then there wouldn't be, unless there's a toxicity issue, where you have to switch and actually stop the medication. There's no evidence that any of the other 3 or 4, if you include ceritinib, have got any activity after the use of lorlatinib.
Okay.
So if you are, so I would agree. I think if you're using lorlatinib first line, then at this point, if it happened today, for example, you would be on lorlatinib, and then it would be non-TKI treatment today. How that might change with obviously the ALKOV trial as well that Ben discussed is something that will come in the future. But if someone was to start lorlatinib today and be on it for 2 years and then need to come off that TKI, well, let's say 2 years is today, then you wouldn't be able to access another TKI in Britain.
Right. It's more resistance.
Does that answer your question?
Yeah, it's more resistance than
Exactly.
toxicity that stops it.
So yeah, exactly. So for that reason, there wouldn't be any evidence that the resistance that comes from being on lorlatinib would be able to be targeted by any of the other TKIs.
Do we have any more questions? Yes, we do. Over the other side.
Seeing that lorlatinib is sometimes now being prescribed first, and it does have a high toxicity and tolerance level, is there fine-tuning going on in terms of dosage? Because it seems to be that you know, you just sort of start on the full dose and then see how you go. Are there other criteria to consider with dosage in terms of tolerance other than just start on the full dose and see how you go?
Yeah, there have been many patients who even in the second, third, fourth line setting, who have been on lorlatinib and whose toxicity have been managed well due to a dose reduction, and some in which that's not been the case, and other things have been helpful to help with the toxicity, depending on the side effect. But yes, you would start at what is deemed from the early phase trials as the optimum level, which is the full dose. But there is in all TKIs there is room for dose reduction, and on purpose. That's how TKIs work. So you're switching off the signal, and then there is room for then dose reduction, and it's still being efficacious and still getting an effect. But then the toxicity is then alleviated. That's not the case for every single toxicity for every TKI, but with what you've asked specifically, lorlatinib, there are some toxicities which can be managed with a dose reduction. And I'm sure you know, your oncologist would be able to gauge that with you.
Okay. Do we have any more questions? Going to wrap up if we don't, because I know you are due on the wards, Dr. Ghosh. Yes, there is one. She looks quite keen. She's waving her hand.
It's not a question, it's a comment actually regarding type of mutations when lorlatinib is used as first line. So studies have shown that actually the type of mutations which occur when lorlatinib is used first line is different. So most of these mutations are actually off target. So this means that they are not happening on the ALK molecule as such. So they are somewhere else in other parts of the cell. So this actually is very worrying because it means that it will be very difficult to use another TKI after lorlatinib first line. So on the other hand, mutations which are happening when lorlatinib is used second line, so meaning that after brigatinib or alectinib, lorlatinib, and mutations which are happening in this situation when laratinib is used second line, are most of them are actually on target. They are called compound mutations, so they are still quite serious, but they are targetable. So it means that other TKIs can actually target it. So, for example, the Nuvalent 655 would be able to block these mutations. So this is something which actually should be taken into serious consideration when laratinib is advised to be used as a first line. So because it's going to be very difficult to find another medication, another type of treatment to follow. Probably chemotherapy would be the only option, really, unless there is another target, like MET, for example, which can be targetable. So this is a comment.
Okay. Thank you, Elena. We've got one more question, I think, from a lady over here. That's it.
Hi.
And then I think you do need to go, Dr. Ghosh.
Okay, just I wondered what if there was any thought about mixing any of these drugs together or mixing any other stuff in, having a cocktail.
Yeah, no, it's a good question because so many years ago, before kind of when we were earlier on in the ALK setting, but we did, there was a trial with EGFR and EGFR TKI and chemo, for example, and the toxicity was very severe and the trial was stopped. This is like, let's say 15 years ago, I'm just putting ballpark 10, 15 years. Mixing TKIs themselves would be, you'd think that's great because you're targeting then acquired mutations, resistance mutations. But there is a trial that will be coming up that we're looking at with an ALK TKI and immunotherapy. For example, we don't think immunotherapy is great on its own necessarily in general for most ALK cancers at the beginning anyway. But there's definitely work going on with combining TKI and immunotherapy. So that you're kind of avoiding the chemotoxicity, but then you've got the immunotherapy. So that's another, I know that Ben had different points using it earlier, you know, in the neoadjuvant setting, et cetera, the Nuvalent stuff going on, finding a cure. But then I think the other thing is in combination with other non-TKI treatments. That will be the next thing as well, one of the next things.
Okay, thank you very much indeed. I'm going to stop the questions and say that if anyone's got any burning questions, if you send them in to us, we'll collate them. And I'm sure Dr. Ghosh will be very happy to respond on paper or on email, and I can distribute the responses. So can I thank you very much indeed, Dr. Ghosh, for taking the time, because I know that you are on ward round. So we do really appreciate you making yourself available. So thank you very much indeed. Oh, just get her off. Okay, John, you did enough, had you? I must remember he has that ability.
Oh, thank you.
Sorry, Doctor.
Thank you.
No.
Because normally when if I do a talk, then and I would always want to say thank you to you and to all of you to allowing me to come, and it's an honor to come and speak to you and answer questions or just discuss with you what you're thinking of, what's going on with all of you and what we're doing here. So I didn't get that opportunity at the beginning because Deborah just dropped me in the deep end and asked me a question right there. So I just wanted to take this opportunity to say thank you honestly very much. It's an honor. I'm happy to come off the ward round and speak to you, but I do need to go back now. But honestly, it was an honor to come, and thank you for listening to me warbling on, and sorry about the sound thing. That was my fault in the middle there. So sorry about the flow with coffee and things.
That's lovely. Thank you very much indeed. Thank you.